Today, we're standing at the portal of modern era of medical treatment, where prescribed medicines are tailored for specific patients. You might have heard of what is called personalized medication. That's the future of medical care. In the future, the characteristic genome, the complete set of genes of a person will be the basis in the diagnosis and treatment of a disease. Since the genome is unique for an individual, then the patient's ailment requires pinpoint medication, a kind of smart medicine that by virtue of compatibility is expected to deliver maximum potency. This future scenario is made possible by the advent of modern computer techniques in drug discovery and development. Now, the health professionals are able to identify certain abnormalities in the body and understand the pathogenesis of the disease at the molecular level. Likewise, computational tools help the scientists in developing or in searching for new compounds that can be used to combat the disease. In a bit, I'm going to describe to you how medicines are discovered using these computer programs. In other words, discovery at the fingertips. But before I proceed, let me refresh you on how the medicines or drugs were discovered in the past. You might have learned of how, by chance, penicillin was discovered. In 1928, Alexander Fleming was looking for new bacterial species, but he accidentally contaminated one of his petri dishes with spores of a fungus he later identified as Penicillium notatum, although it was actually Penicillium rubens. He noted that in the area where the mold grew, there was no bacterial growth. Apparently, the mold secretes a compound that kills the bug. That compound is penicillin, the prototype of more than half of the antibiotics that we use today, including the penoms like amoxicillin and ampicillin, the penims, the cephins like cipaclor, monobactams, and all other beta-lactam-based antibiotics. It is by accident or serendipity that penicillin, the first miracle drug, was discovered. How many of you here are experiencing some symptoms of allergy, like sneezing, runny nose, peptic ulcer, acid reflux, or asthma attack? Well, you are fortunate that you do not live before the time the first antihistamine was discovered. If you have allergic reaction to dust mites, pollen, some food and drugs, how can you live a comfortable life without antihistamines like Benadryl, Claritin, Clarinex, to name a few? Dr. Bovet, a Swiss biochemist who won a Nobel Prize in medicine, was instrumental in the discovery of sulfanilamide, the first of the so-called wonder drugs against infection. Of equal importance is his discovery. Of the first antihistamine. You know what? In 1940, Dr. Bovet had to conduct more than 3,000 experiments in order to arrive at the first antihistamine. I can imagine how Dr. Bovet experimented or tested with all these combinations of atoms and structures and geometries, as well as the different dosage forms in order to come up with the first antihistamine that we use today. Nevertheless, the discovery by trial and error method of Bovet gives us access to these antihistamines. Before the advent of computer technology and computational methods in biochemistry and medicinal chemistry, drugs are discovered this way, by trial and error or by hit or miss approach. And once in a while, like in a blue moon, in the case of penicillin, drugs are discovered by serendipity. This practice has been continuously employed in small laboratories in different academic and government institutions, mostly of developing countries. Inspired by the amazing richness of biodiversity in these countries, their local scientists move heaven and earth with their meager resources to look randomly for new compounds that can combat a certain disease. In this search, at times, they are guided by folkloric information. But usually, the choice of the target is based on personal bias and research convenience. It is seldom an exhaustive, systematic exploration of chemical space. In contrast, the well-equipped pharmaceutical industries have been using what is called computer-aided drug discovery in finding new therapeutics. The main feature of CAD is the utilization of cutting-edge computer techniques in understanding the intricacies of biological processes associated with the disease, in the visualization of the drug target, in a seamless screening of compounds in a short period of time at a very reduced cost. This is discovery outside the normal laboratory condition. Now you can design drugs at the comfort of your own home, in your car, in a park, or any place convenient to you. With the use of your laptop or iPad, you can now rapidly screen compounds that can be downloaded from the internet. So this revolutionizes the drug discovery process. The drug discovery process is an intensive and expensive endeavor. To develop a drug, it will take typically 12 to 14 years, and it costs around $2 billion US. It involves more than 10,000 health professionals and scientists, involving the different disciplines like biology, medicinal chemistry, cheminformatics, and bioinformatics. The first step is the identification of the drug target, which is usually a protein in the body that is involved in the mechanism of the disease. A protein is a chain of amino acids. Those letters represent amino acids. These codes can be converted into a three-dimensional structure, like this one. And this is a target of the design of a new drug. This approach is called structure-based design in drug discovery. The structure-based design has been used in the discovery of more than 40% of the drugs that we have now today, including Cap10 for hypertension, Trusol for glaucoma, Viracep for AIDS, Tamiflu for influenza, and Gleevec for leukemia. So, initially, the protein target is modeled like this one. And then, after obtaining a model of the drug target, one can perform either high-throughput screening or virtual screening. In high-throughput screening, robotics are used, but it also involves computer software for control and data processing. More importantly, it involves expensive chemicals and liquid handling devices and detectors that can add to the expenses in drug discovery. In contrast, virtual screening like molecular docking, molecular dynamics, and de novo design involve much less cost. In de novo design, the drug is assembled at the binding pocket of the target protein, either by growing or linking. In growing, a fragment of the drug is anchored to the binding site and is allowed to grow either randomly or intuitively until it reaches an optimum size and shape and strength of interaction with binding pocket. In linking, the different fragments are attached to the binding site and they are assembled by using a linker or a tether. In virtual screening, a kind of model of the drug is generated. It's called a pharmacophore. This pharmacophore is used in screening compounds. The program looks for similar compounds or compounds that satisfy the requirements or described in a pharmacophore. There are sophisticated programs available today that can perform automated searches and returns invaluable hits that can be further studied. The hits can be further examined for their interaction with the drug target using the technique called molecular modeling, molecular dynamics, and molecular docking. In molecular docking, the compound hovers over the binding pocket, and it takes different poses. Each pose is evaluated, is scored. The pose with the highest score and the compound with the highest binding energy as a criterion is expected to deliver the maximum potency. So the compounds that are evaluated are rank ordered, put in a list, and those found at the top of the list are handpicked for further development. In molecular dynamics, the atoms and velocity of the position and the velocity of the atoms are calculated. And this gives us kind of video clip on how the molecules, the ligands, the protein move in space and in a medium. This information on simulation studies are very helpful in subsequent step in drug discovery called lead optimization. In lead optimization, the compound is further tweaked so that its potency is further improved and some issues on ADMET are addressed. ADMET is an acronym that stands for absorption, distribution, metabolism, excretion, and toxicity. An effective and safe drug must meet the ADMET criteria. It must be easily absorbed by the body. It must be easily distributed so that it reaches the target site. It must be stable enough, but can be metabolized in order to prevent unnecessary buildup in the body. And most of all, it should be non-toxic with less side effect. So, only the most effective and safest drug candidate is actually prepared or synthesized in the laboratory and tested experimentally. This saves a lot of time and resources that would have been wasted in a hit or miss experiment that's usually done in most laboratories. The information that can be obtained from this biological or experimental data can be further utilized in another technique called quantitative structure-activity relationship studies. You know, a structure of a molecule has so much information in it. And so we mine this data in order to determine which parameter or property of a molecule dictates the actual potency or activity of a drug. So an equation is generated like this. It's highly technical, but this allows us to know which part or which parameter should be adjusted so that we get the maximum potency and drug-like property. We have exploited all this computer-based techniques in discovering new TB drugs or anti-TB drugs. We are interested in TB because this is a major public health concern. 1/3 of the global population is infected with TB. So if this statistics applies here, it's either you or one of the persons sitting beside you has infection. You ask yourselves. Another one is the TB drugs that have been administered today are almost half-century old, and they are becoming less and less effective because of the emergence of resistant strains. You have heard of superbugs, right? The germ that causes TB is also becoming a superbug. So we need to develop new super drugs for TB. Unfortunately, the profit-oriented drug companies are less interested in developing drugs for tropical diseases like TB for obvious reasons. And so we must have our own contribution. In our lab, we've got no robots. And definitely we don't have enough fund to perform millions of conventional bioassay on these compounds. But we have a handful of powerful computers with decent softwares that can perform all these processes, computer-aided processes that I have just described. In our 2 years of research on TB, we have already virtually screened over 10 million compounds and handpicked around 100 hits and actually tested 20 compounds after performing some filters. We are very delighted with our initial results of having found 2 leads with potency that can be comparable to drug candidates and even medicines used today. Our research is a glaring example that even a modest laboratory can give a great contribution in drug discovery, thanks to the accessibility of modern computer-based techniques. The drug discovery approach in the past is like finding a needle in a haystack by manually sorting all the materials in that packed pile of hay. With computer-aided techniques, it's like passing a strong magnet over the haystack and effortlessly pulling the needle out of the pile, leaving the hay behind, essentially unscathed. That's the power of computer-aided drug discovery. I hope you now realize that the race between the disease and the drug is now being played at the desktop. The victory over the disease literally lies in our hands. We will certainly lose if we fail to lift a finger. Thank you for your attention.